Welcome back to the deep dive. It is Tuesday, February 10th, 2026. And let's just take a second to ground ourselves in that date.
2026.
Yeah, 2026. We are standing at what feels like a very specific, a very consequential moment in time, not just for the world, but specifically for the subcontinent.
We are. And honestly, if you look at the stack of reports and the budget analyses and all the policy papers we've gone through for this, it really feels like we're looking at a split screen of a nation.
That's the perfect visual, a split screen. Because on one side of that screen, you have this rising economic giant, right?
Absolutely.
We're talking about India in 2026. It's a tech superpower. You've got the GDP just moving up and to the right. You've got space missions. You have this digital infrastructure that, frankly, the rest of the world is a bit jealous of.
They are.
But then you look at the other side of that split screen.
And that side feels heavy. It
Yeah.
feels like an anchor dragging on the seabed while the ship is just trying to go full speed ahead.
Exactly. Because despite all that growth, despite the skyscrapers and the startups, we are looking at a reality where a huge portion of the population is continuously weighed down by preventable illness and, let's be honest, the financial ruin that comes right along with it.
It is the paradox of power. That is really the core theme we are unpacking today.
It really is.
How can a country be so rich in potential, so rich in innovation, yet still struggle so profoundly with the biological basics of just keeping its people alive and healthy?
We have a massive stack of sources today to help us answer that. We're looking at the 2026 union budget analysis. We have reports on the Ayushman Bharat scheme, some really fascinating deep dives into AI and medical training, and then these comparison case studies from Brazil, Thailand, and Rwanda.
A lot to get through.
A lot. And the mission, if you want to call it that, of this deep dive is to answer one fundamental question.
It is the trillion-dollar question. I mean, literally.
It is. The question is, can a lower middle income country of 1.4 billion people actually deliver dignified healthcare at scale? Or is that just, a pipe dream? Is it just good marketing?
And to answer that,
Yeah.
we have to look at what some of our sources are calling a civilizational approach.
I circled that phrase in the notes 3 times. Civilizational approach. It sounds incredibly epic, almost like something out of a sci-fi novel or a history book.
It does, but it's actually very grounded in the messy reality of 2026. It's this unique experiment where India is attempting to fuse ancient wisdom.
Okay.
We're talking yoga, Ayurveda, community kitchens,
Right.
with absolute frontier technology like AI, robotics, and these digital nervous systems.
So we're going from yoga mats to neural networks.
Precisely. We're seeing if you can take the oldest traditions and the newest codes and just smash them together to solve a problem that money alone hasn't been able to fix.
I love that. So let's start with the hard reality, the diagnosis. We have to look at the numbers. We just saw the 2026-27 union budget. Now, usually budget analysis puts people to sleep. I know. But this year, the numbers are screaming at us. What's the headline here?
The headline number looks big on paper, and that's by design. The allocation to the Ministry of Health and Family Welfare is 1,06,530 crore rupees.
So 1,006,530 crore.
Which is roughly a 10% increase from the previous year.
Okay, so double-digit growth. If I got a 10% raise at work, I'd be pretty happy.
That sounds like progress, doesn't it?
It sounds good in isolation,
Yeah.
Of course. But in economics, as in life, context is everything.
Right.
When you zoom out, that huge-sounding number only represents about 1.9% of total government spending.
Only 1.9%.
And more importantly, and this is the number that really, really matters, public health spending is still just hovering around 0.5% of GDP. 0.5%. Wait, let's pause there. That seems incredibly low. I mean, for a country that wants to be a superpower, 0.5% of your gross domestic product goes to health.
It is remarkably low. For context, the National Health Policy back in 2017, that's almost a decade ago now, set a target to reach 2.5% of GDP.
2.5% was the target.
That was the target. We're in 2026, and we are still at a fraction of that. We're essentially missing our own targets by a country mile.
So why? I mean, the economy is growing, tax collections are up, we see the roads being built, the airports being built. Why is health getting the short end of the stick?
It's complicated, and it has to do with let's call it the plumbing of how India is structured politically and financially. That 0.5% figure, that's just the central government's share.
Oh.
In India's federal structure, the center contributes only about 0.29% of GDP to health. The states are supposed to shoulder the rest.
So the heavy lifting is on the states.
Exactly. Health is primarily a state subject in the Constitution. The center sets the policy, provides the vision, and yes, some funds, but the actual hospitals, the doctors, the day-to-day running, that's on the states.
And the states don't always have the money.
The reality is many states are fiscally stretched. They're broke, or they prioritize other things that might yield faster political returns. A new highway is more visible than a new primary health center.
So when you add it all up, public plus private spending, where does India land?
If you take everything, what the government spends and what people spend themselves, we're at about 3.31% of GDP total. But here's the scary part.
Okay.
The majority of that isn't the government paying. It's out-of-pocket expenditure, or OPE.
That's the money coming directly out of a regular family's wallet when someone gets sick.
Right. And in India, that is still hovering between 39% to 47%, depending on which state you look at.
39 to 47%.
Yes. In many developed nations, that number is in the single digits. This is what economists call medical impoverishment.
That is a terrifying phrase. Medical impoverishment. It sounds like a trap.
It is a trap. It's
It is.
literal. It means illness isn't just a health shock. It's a financial catastrophe.
It just wipes you out.
It pushes families into debt, forces them to sell their farmland, sell their jewelry, or pull kids out of school to work. You are one bad diagnosis away from losing your entire economic footing.
So you could spend 20 years building a middle-class life.
And one cancer diagnosis sends you right back to poverty. It's that brutal.
I remember reading a quote from MP Raghav Chadha in our research stack. He talked about one nation, one medical treatment.
It's a powerful concept.
It is. The idea that healthcare shouldn't be a privilege based on your zip code or your bank balance. But when I look at these out-of-pocket numbers, the gap between that vision and the reality feels well wide.
It's a chasm.
Yeah.
It really is. And the sources highlight that the infrastructure gaps are still massive. Rural India is facing an 80% shortage of specialists. So even if you have the money, you might not have a doctor nearby who can actually treat you. You have the cash, but there is no surgeon.
Wow. An 80% shortage.
It's a huge deficit.
Right.
And it's not just about infectious diseases anymore, right? I feel like 10, 15 years ago, we always talked about malaria or TB or cholera.
That's a focus.
That landscape has shifted completely. We're now facing what the medical community calls the silent killer, non-communicable diseases, or NCDs.
Give me some examples. What are we talking about?
We're talking about diabetes, hypertension, cardiovascular issues, cancer. These are chronic conditions. They don't just go away with a course of antibiotics.
No, they require lifelong management.
Lifelong management, they drain productivity and resources for decades.
And they are expensive.
Incredibly expensive. A heart patient needs meds every single day for 30 years. A dialysis patient needs treatment every week. If you're paying for that out of pocket without a safety net, you are finished. And these diseases are hitting younger people now, the workforce.
Okay, so we have underfunding, a specialist shortage, and a rising tide of chronic disease. That is a tough diagnosis. But the budget did have some specific increases, didn't it? It wasn't all flat lines.
True. There are signals of where the government's head is at. The PM Ayushman Bharat Health Infrastructure Mission got a massive 67% increase.
67% is huge. What is that money actually for?
That is for the hardware, building physical capacity.
So brick and mortar.
Brick and mortar, trauma centers, critical care blocks in districts, integrated public health labs. It shows a realization that insurance is useless if there is no hospital to go to.
Right.
You can have the best insurance card in the world, but if the hospital doesn't exist, it's just a piece of plastic.
I also noticed the Ministry of Ayush got a 20% bump. That goes back to that ancient wisdom theme we touched on earlier.
It does. AYU's stands for Ayurveda, Yoga, Unani, Siddha, and Homeopathy. The government is betting big that traditional medicine can handle the preventative side, keeping people out of the expensive hospitals in the first place.
We will definitely get to the prevention part because I think that is fascinating and controversial in some circles. But first, we have to talk about the 800-pound gorilla in the room.
The safety net.
The safety net. Ayushman Bharat, or PMJA.
The world's largest health assurance experiment. And I use the word experiment deliberately because at this scale, everything is uncharted territory.
It really is massive. I mean, the scale of everything in India is big. We're used to big numbers, but this is on another level entirely.
It is. We're talking about coverage for the bottom 50% of the population. That is 55 crore individuals.
Let's put that in context for our listener. 55 crore is 550 million people. That is more than the population of the United States, Canada, and Mexico combined, all covered under one single scheme.
Correct. And the core promise is a 5 lakh rupee coverage per family per year for secondary and tertiary care.
So that's for hospital stays, surgeries, things like that.
Exactly. Not for your day-to-day cough and cold, but for the big expensive stuff that bankrupts people.
And the key features. What makes it work?
The first two are cashless and paperless. This is critical. In the old days, you had to pay up front and then file a claim to get reimbursed.
Which is impossible if you're a daily wage laborer. You don't have 50,000 rupees lying around to pay up front for a surgery.
Exactly. So the poor just didn't get treated. They suffered at home or they died. With PMJAY, the hospital claims directly from the government. The patient just walks out.
And the other feature.
And it's portable.
Portable meaning?
Meaning a migrant worker from Bihar who is working on a construction site in Kerala can walk into a hospital in Kerala and get treated. The data follows him. His eligibility is national.
That is a logistical nightmare to solve, but if it works, it's absolutely brilliant. But there was a game changer in 2024, right? The sources made a big deal about this expansion.
Yes, this was a pivotal moment. In 2024, the government expanded the scheme to include all citizens aged 70 and above, regardless of their income.
Regardless of income. So even if you are a wealthy person, if you're over 70, you're covered by this.
Exactly. And this is fascinating because it shifts the philosophy of the program. It started as a poverty alleviation tool, helping the poorest of the poor.
Right.
But by including all elderly citizens, it's becoming a proto-universal coverage system for the elderly. It acknowledges that geriatric care is expensive for everyone, not just the poor.
That is huge for the sandwich generation, right? People in their 40s and 50s taking care of aging parents while also raising their own kids.
Ideally, yes. It takes a massive financial load off them. One hip replacement for dad can wipe out the savings for the grandkids' college fund. This is designed to stop that. It de-risks aging.
So it sounds great on paper, the vision is incredible, but we are the deep dive. We don't just read the brochure. How is it actually working on the ground? It's 2026 now. What's the report card?
It is a mix of impressive stats and, let's say, persistent friction.
Okay.
On the positive side, over 33,000 impaneled hospitals, over 7 crore hospitalizations authorized, and more than 35 crore cards have been issued.
Those are enormous numbers, 7 crore hospitalizations.
They are. And studies show it has reduced that scary out-of-pocket expenditure by 30% to 50% for beneficiaries. That is real money staying in people's pockets.
So it's working in that sense?
In that sense, yes. It has also incentivized private hospitals to open up in Tier 2 and Tier 3 cities, because now there's a paying market there.
Ah, that's interesting.
Before, a private hospital wouldn't open in a small town because nobody could afford them. Now everyone has a card. The demand is there.
But I'm sensing a however coming. There's always a however.
There is always a however. The biggest challenge is reimbursement rates. The government sets a price for a surgery, say a knee replacement. Private hospitals often argue that these rates are just too low to be sustainable.
So the government says, we will pay you $50,000, and the hospital says, but it costs us $60,000 just to turn the lights on and pay the surgeon.
Exactly. So what happens is many of the big, high-quality corporate hospitals hesitate to join, or they'll cap the number of Ayushman patients they see.
So they treat it like charity work.
They treat it like charity work rather than a core business. So you have the card, but you might not get the bed in the best hospital. You might still be seen as a second-class patient in a way.
In some places, yes. And then there are the infrastructure gaps we talked about. The scheme is portable, which is brilliant.
But that only works if the hospital in Kerala has space, and if there's a hospital in the workers' home village in Bihar for follow-up care.
Right. Insurance is just a payment mechanism. It doesn't build the hospital walls or train the nurses.
Precisely. The expert analysis in our notes says it perfectly. The scheme works best where the underlying health system exists. It struggles where the infrastructure is missing. You can't insure your way out of a doctor shortage.
And I assume with that much money flowing, there is leakage.
There's fraud, a lot of it. Overbilling, performing surgeries that weren't needed just to claim the money.
Oh, that's dark.
It is. Things like removing a uterus that didn't need removing. There have been scandals. But this is where the tech comes in. They're using AI now to detect fraud patterns, which segues perfectly into the next layer of this civilizational stack.
The digital nervous system.
Exactly.
Yes, the ABDM, the Ayushman Bharat digital mission. The sources compare this to the UPI moment for healthcare. Now, for our international listeners, UPI is the Unified Payments Interface. It basically replaced cash in India in about 5 years. You can buy a cup of tea on the street with your phone. It's ubiquitous.
And that comparison is very deliberate. Think about what UPI did. It made moving money instant interoperable, and incredibly cheap.
Mhm.
ABDM wants to do the exact same thing for medical records.
So describe the before state, because I think anyone who has dealt with the medical system knows this pain intimately.
The before state is the plastic bag.
Yeah.
Every Indian family has a drawer full of plastic bags.
Yes, they do.
In them are crumpled x-rays, faded prescriptions, lab reports from 3 years ago. If you change doctors, you have to carry the bag. If you lose the bag, your medical history is just gone.
And the doctor has to start from scratch. Do you have allergies? I don't know. It was in the bag my mom lost.
Exactly. It is profoundly inefficient and, frankly, dangerous.
And the after state. What's the vision?
The goal is one citizen, one health ID, it's called the ABHA, leading to a lifetime medical record that's accessible anywhere, anytime, with your consent.
How many people have these ABHA ADs now in early 2026?
The latest numbers are over 85 crore.
Wow. That is most of the country. The adoption has been huge.
It's massive adoption. And it's not just an ID card. It connects to the Unified Health Interface, the UHI. This is an open protocol.
Explain open protocol in plain English for us.
Think of email. You can have a Gmail account. I can have an Outlook account. We can still send emails to each other. We don't both need to be on Gmail.
Okay, I get it.
UHI is like that for health apps. Different apps can talk to each other. You could book an appointment on a government app, get your lab results on a private app, and then share them with a doctor who's using the hospital's internal system.
So it's breaking the data silos.
Exactly. No more being locked into one hospital system. But the part that I find most futuristic and uniquely Indian is the language aspect of this.
Oh, you mean the Bihachinar project integration?
Yes. India has hundreds of languages and dialects. A doctor in Delhi might speak Hindi and English, but a patient might come in speaking Bengali or Tamil or a tribal dialect. In the past, this was a massive barrier. Misdiagnoses happened just because of translation errors.
So how does ABDM fix that?
They are integrating real-time AI translation tools into the platform. The ABDM allows medical advice and records to be instantly translated into the patient's native tongue.
That is incredible. It completely democratizes access. You are not penalized for not speaking English or Hindi.
And it moves healthcare from digitization to intelligence. We aren't just scanning PDFs of old reports anymore. We are creating computable data.
What's the
A
difference?
scanned PDF is just a picture of words. Computer can't read it. Computable data means the system knows that this number is your blood sugar level, and this word is the name of a medication.
Ah.
So if you have that data on millions of diabetic patients across the country, an AI can start to spot patterns. It can predict outbreaks. It can say, hey, why is kidney failure rising in this specific district? Is it the water? Is it the diet?
It's the Fed hackathon concept that was mentioned in the notes, using all this data to solve big public health problems.
Exactly. But, all this high-tech stuff, AI, digital IDs, insurance, it's all treating sickness. It's all reactive. You are sick. Here is how we manage it.
What about not getting sick in the first place? Because that seems to be the only way to make the math work in the long run.
The quiet army of prevention. This is where India flips the script and looks backward to look forward.
Back to the yoga mats.
Back to the yoga mats. And it's easy to dismiss yoga as just a fitness trend for wealthy people in the West or a purely spiritual practice. But the sources are very clear. We need to view it as evidence-backed preventive medicine.
Right. The notes mentioned cardiovascular health, inflammation reduction, pain management for things like arthritis.
Exactly. Think about the Indian workforce. A huge percentage involves manual labor, agriculture, construction. If you have a population prone to arthritis and back pain, yoga is an incredibly low-cost intervention. The proposal is to embed it in schools and workplaces.
So it's essentially free infrastructure for the body.
That's a great way to put it. And then there's the food aspect. We can't talk about health without talking about nutrition.
Of course.
The midday meal scheme is already a huge success story, feeding 120 million children every day. It reduces stunting. It improves school attendance. But the sources point to a new idea for adults, the Langar model.
I love this. For those who don't know, Langar is the Sikh tradition of community kitchens. They're usually attached to a gurdwara, a Sikh temple, and anyone, absolutely anyone, can get a hot, nutritious meal for free.
It is brilliant because it turns food security into moral infrastructure. It's not just a government handout. It's community-driven. It's about dignity. The idea is to adapt that model to ensure vulnerable adults get at least one nutritious meal a day.
So it's not just calories, it's dignity and community.
Correct. If you combine better nutrition with active lifestyles, you start to chip away at that NCD crisis we talked about. You prevent the diabetes before it starts. You lower the blood pressure before the stroke happens. That's the only sustainable path forward.
It's a holistic picture. But I want to zoom out a bit. We're looking at India, but the world is big. How does this compare to what other countries are doing? The sources spent a lot of time on Brazil.
Yes, the Brazilian model, SUS Sistema Único de Saúde, the unified health system, is probably the closest parallel to India in terms of scale, inequality, and just the sheer ambition of it all.
So, why Brazil? What can India learn from them?
Brazil established SUS back in 1988. This is important context. They had just ended a military dictatorship. They wrote a new constitution. And their core philosophy is radical.
How so?
It's that health is a right of the citizen and a duty of the state.
That is a very different framing from insurance, isn't it?
Very different. In an insurance model, like Ayushman Bharat or the U.S. system, you're a consumer with a policy. You have coverage limits, co-pays. In Brazil, you are a citizen with a right. You don't need a card, you don't need to enroll, you just walk into a public hospital. It covers everyone.
Yep.
Citizens, tourists, undocumented migrants, everyone.
That sounds incredibly expensive and complicated.
It is ambitious.
Yeah.
And it has had huge successes. Their organ transplant program is a world leader, mostly public funded. Their vaccination reach is incredible. And about 72 to 75% of Brazilians rely entirely on it for their care.
But I feel another but coming.
But chronic underfunding. Sound familiar? They spend about 4% of GDP on public health, which is way higher than India's 0.5%, but it's still below the WHO recommendation of 6%. The result is long wait times and ultimately a two-tier system.
The rich buy their way out of the line.
Exactly. There's a parallel private insurance market for the top 25%, the wealthy and the upper middle class. So while the ideal is universality, the reality is hybrid.
So what's the lesson for India?
The lesson for India is that you can achieve universality in a developing nation. Brazil proves it's possible, but if you underfund it, you just create a system where the poor wait and the rich pay. It's a powerful warning.
That feels like a very clear warning. If India wants Ayushman Bharat to be truly universal one day, it cannot underfund the supply side.
You can't promise the moon and pay for a flashlight.
What about other models? We have Thailand and Rwanda in the mix too.
Thailand is the poster child for universal health coverage, or UHC, achieved with tax financing. Their big lesson for India is gatekeeping.
Gatekeeping. That sounds negative, like you're trying to keep people out.
It sounds negative, but it's about necessary efficiency. It means you can't just walk into a specialist's office or a big tertiary hospital because you have a headache. You must see a general practitioner or a primary care doctor first.
Ah, so it's a filtering mechanism.
Right. This prevents the big, expensive hospitals from getting clogged with minor ailments that could be treated for much cheaper at a local clinic.
India's trying to copy this with the new health and wellness centers, right?
That's the idea. Fix the front door of the system. If you can treat the fever in the village clinic, you save the bed in the city hospital for the heart attack patient who actually needs it.
That makes a lot of sense. And Rwanda.
Rwanda is fascinating. They pioneered performance-based financing.
Explain that concept.
Okay, so usually, healthcare providers are paid for services. Did you run a test? Here's $10. Did you do a scan? Here's $50.
Which incentivizes doing more stuff.
Exactly. It encourages over-testing, over-treatment, not necessarily making people better. Rwanda flipped it. They started paying doctors and clinics based on outcomes. Did the patient get better? Did the mother survive childbirth? Did the child get fully vaccinated?
That seems incredibly smart. Instead of incentivizing activity, you incentivize health.
Exactly. And then you have this whole world of frugal innovation. The sources mention Kenya's solar-powered clinics or the $80 Remotion prosthetic knee.
$80 for a prosthetic knee.
Yes. It's a reminder that innovation isn't always high-tech robots. Sometimes it's about radical affordability. It's about designing for the environment you actually have, not the one you wish you had.
Okay, so we have the diagnosis, the insurance layer, the digital layer, and the global context. But we keep coming back to this one fundamental bottleneck. We talked about it right at the start.
The human element.
The shortage of humans.
Yeah.
We simply do not have enough doctors and nurses.
And we cannot build medical colleges fast enough to fix it. The math just doesn't work. The target ratio is 1 doctor for every 1,000 people. Some sources say it's 1 for every 834. We're chasing that target, but the population grows faster than the graduation rates. and it takes 10 years to train a specialist.
The brick-and-mortar solution is too slow. So enter the robots.
Not exactly robots replacing doctors. At least we aren't there yet. Think of it as AI as the infinite tutor.
Explain that. That's a great phrase.
The sources describe a massive initiative launched in January 2026 by the National Board of Examinations in Medical Sciences, the NBEMS. They launched an online AI training program for doctors.
And this isn't just a Zoom class with a PowerPoint.
No, not at all. This is using AI to democratize elite knowledge. Imagine digitizing every lecture from the top institutes, AIMS, AIs, IMs, and using AI to translate them and then create personalized tutors for students in local languages.
So a student in a rural district can get the same quality of education, or at least access to the same information, as someone in New Delhi.
Exactly. And the AI tutor never sleeps. It can answer questions at 3 a.m. It can customize the curriculum on a fly. If you are struggling with cardiology but you're acing neurology, the AI adapts. It gives you more cardio cases. It creates a personalized learning path for every single student.
It reframes AI not as a job thief, but as an educational force multiplier.
Precisely. And the uptake was instant. Over 40,000 doctors enrolled immediately. The hunger for knowledge is there. The access was the problem.
I was really struck by the nursing education part of this, too, the flight simulator concept.
This is crucial. Nursing is hands-on. You can't learn it just from a book. But you also don't want a student practicing their first injection on a real patient if you can possibly avoid it.
Right. Ouch. No, thank you.
So they're using virtual reality and augmented reality with haptic feedback.
Haptic feedback means they can actually feel it.
Yes. They wear gloves or hold instruments that provide physical resistance. They can feel the pop of the needle entering the vein. They can feel the texture of the tissue in a simulation.
So they can practice high-stakes scenarios, a trauma case, an ICU crash, virtually.
Exactly. They can make mistakes, kill the virtual patient, learn from it, and then just hit reset.
That is incredible. It accelerates experience without risking lives.
It creates what one source called a synthesizer of intelligence. The future doctor or nurse isn't competing with the machine. They are trained to synthesize their human judgment with the algorithmic insights. They stop memorizing facts because the AI knows all the facts, and they start mastering decision-making under pressure.
That is a profound shift in what it even means to be a doctor.
It is. It shifts the entire profession from being memory-based to judgment-based.
So if we pull all these levers, the insurance, the digital data, the prevention, the AI training, what does it mean for the economy? Because usually health is seen as a cost center. Politicians look at the budget and groan, oh, we have to spend all this money on health.
That is the old way of thinking. One of our sources, Paramendra Kumar Bhagat, had some posts that reframe this entirely. He calls it a $10 trillion opportunity.
10 trillion. That is a lot of zeros. How do you get to a number like that?
Well, the logic is sound. The argument is that health is not a cost, it's an investment. A healthier population is a more productive population.
Right. You can't build a superpower with a sick workforce. If everyone is taking sick days or retiring early because of diabetes, your GDP suffers immensely.
Exactly. That demographic dividend, that huge young population that India has, is only a dividend if they are healthy. If they're sick, it's a demographic drag. It's an anchor on the economy.
But there's also a direct revenue stream here, isn't there?
Yes, medical tourism.
Oh, right. People coming to India for treatment.
It's projected to reach $13 billion by 2026. 2 million international patients a year.
That is a real industry. Why do they come?
It's the combination of quality and cost. You can get world-class heart surgery in India for a fraction of the cost in the US or the UK with basically zero wait time.
And the strategy, which is clever, is to use that revenue to help the locals, right?
Exactly. Use the high margins from treating wealthy international patients to cross-subsidize the domestic public healthcare system. Use the profits from treating a patient from Dubai to fund the base of the pyramid.
That's the Robin Hood model of healthcare.
In a way, yes. But to make any of this sustainable, we have to loop back to the very beginning. The consensus in all our sources is crystal clear. India must reach that 3% of GDP in public health spending.
That is the magic number.
It's the threshold. The estimates say it's about 11.28 lakh crore. If you hit that number, you can cut out-of-pocket expenditure down to 30%. You stop medical poverty. You stabilize the entire system.
It feels like we're so close and yet so far. The tools are there, the tech is there, the plan is there. It's just a matter of execution and funding.
It is political will and fiscal courage. It is choosing to build hospitals and train doctors instead of something else. It's choice.
So let's try to wrap this up. We have covered a lot of ground, from the budget sheets to the VR headsets. What is the synthesis here? How do we sum up this civilizational approach?
I think it is the contrast between the old slogan and the new reality. We all know the saying, John High to Jahan High.
If you have life, you have the world.
Right. It's a beautiful, timeless sentiment.
Yeah.
But the new reality in 2026 is that life doesn't just exist in a vacuum. Life runs on hospital beds and digital bites.
Right.
It requires the yoga mat and the neural network. It needs the community kitchen and cloud computing.
It is a hybrid survival strategy.
Exactly. It is blending the best of the ancient low-cost traditions with the absolute cutting edge of high-tech efficiency. It's an attempt to leapfrog the mistakes that the West made over the last century.
And it leaves us with a pretty heavy question to chew on.
It does, and this is what I want the listener to really think about as they go about their day. We just discussed AI teaching doctors. We discussed digital IDs tracking your entire health history from birth. We are moving very quickly into a world where an algorithm might know your health better than you do.
That is scary and amazing at the same time.
It might predict your heart attack before you even feel a twinge in your chest. But it raises a fundamental question. If the system knows more than you, does the responsibility for health shift from the individual to the system?
Oh, that is deep.
If you get sick, is it because you made bad choices? Or is it because the algorithm failed to intervene in time? If the system fails, who is to blame? The doctor, the Minister of Health, or the code itself?
Wow, that puts a whole new spin on the phrase taking care of yourself.
It really does. It forces us all to ask, is healthcare a product we buy or is it a right we possess? And in a digital age, is it also a data stream we surrender?
Something to mull over while you're checking your step count on your phone today.
Indeed.
Thank you for diving deep with us. This has been a fascinating look at India in 2026. We will see you next time.